My name is Carolyn Rosales, and I will be presenting treatment for chemotherapy-induced nausea and vomiting. SJ is a 45-year-old female admitted to Day Hospital for her autologous stem cell transplant. To prepare for transplant, she will receive melphalan, a chemotherapy to clear her bone marrow and make space for the new stem cells. Melphalan is highly emetogenic, so she will receive antiemetics prior to treatment that include fosaprepitant, ondansetron, dexamethasone, and Ativan. Day -1, she received her melphalan. Day 0, she received her stem cells, and she now is here, Day Hospital, day +2. Nausea and emesis is a reflux that is the result of activating the vomiting center, a nucleus of neurons in the medulla oblongata. There are direct stimuli and indirect stimuli that activate the emesis reflex. Indirect stimuli first activates the chemoreceptor trigger zone, which then activates the vomiting center. Indirect stimuli that activates the chemoreceptor trigger zone includes signals from the stomach and small intestines that travel along the vagal afferents and emetogenic compounds such as chemotherapy that are carried through the blood. She has no complaints of pain, alert and oriented ×4, normal sinus rhythm S1, S2, normal depth and rate of respiration. She has persistent nausea, but no trouble swallowing. She's just unable to tolerate oral intake due to the nausea. No active vomiting. Diarrhea that has an increase of 3 to 4 stools over baseline. No urinary issues. Normal gait, but feels weak and fatigued. She's in high spirits and knows this is part of the process, as she was informed by the nurses and doctor, and she has good support at home and at bedside by her husband and family members. The first medication that we're going to prescribe will be fosaprepitant, 150 milligrams intravenously over 30 minutes. She did receive a dose of fosaprepitant on day -1 when she was given melphalan. It's now been 4 days, so we will re-administer the fosaprepitant to continue to provide antiemetic coverage. Fosaprepitant blocks neurokinin 1 type receptors in the chemoreceptor trigger zone. Side effects include dizziness, fatigue, diarrhea, liver injury, and hypersensitivity reaction. Drug interactions include inhibitors of CYP3A4, which can raise the levels of fosaprepitant. And by inhibiting CYP3A4, fosaprepitant can raise levels of CYP3A4 substrates that include certain chemotherapies, so this would be a concern in dosing. Inducers of CYP3A4 can decrease the levels of fosaprepitant. And it also induces CYP2D6, which can decrease the levels of CYP2D6 substrates, which include warfarin. So we would need to watch out for warfarin doses if the patient was taking warfarin. It can enhance the response when added as a treatment along with other antiemetics. And aprepitant is the oral form. Concentration may be increased when taken with grapefruit juice, but we're giving IV. The second medication that we're going to give would be ondansetron, Zofran. We'll give 8 milligrams intravenously over 2 to 5 minute push while in day hospital, and then she'll have oral 8 milligrams at home when needed. We'll give her the sublingual tab that can just dissolve so she doesn't have to worry about taking it with water. And then all doses combined will be given every 8 hours. So between what we give IV and what she can take at home, there needs to be an 8-hour time span in between. Ondansetron is a serotonin receptor antagonist, so it blocks the serotonin receptors type 3 located in the chemoreceptor trigger zone and on the afferent vagal neurons in the upper GI tract. Side effects include headache, constipation, diarrhea, dizziness, and it could cause QT prolongation. So in a patient that maybe previously has this issue, we would want to be careful. If taken along with other serotonergic agents, it can cause serotonin spectrum. Predominantly when, like I said, predominantly when used in combination with other serotonergic agents, such as selective serotonin reuptake inhibitors, serotonin and norepinephrine reuptake inhibitors, MAOIs. Some symptoms of serotonin syndrome include mental status change, autonomic change like flushing, diaphoresis, tachycardia, GI changes, neuromuscular changes such as tremor and or seizures. So we would want to watch out for these things as well if we were to prescribe other types of serotonin receptor antagonist drugs. Possible drug interactions include CYP3A4 inducers. That seems to be commonality with a lot of the drugs. So they may decrease the serum concentration of ondansetron. Amiodarone may enhance the QTC, prolonging the effect of ondansetron. Fluorouracil products, so ondansetron may enhance the QTC prolongation effect of fluorouracil. Like I said, like if the other medications are known to also cause QTC prolongation, or the patient already has a problem with the QT prolongation, we need to be careful. Metformin, it may increase the serum concentration of metformin. Tramadol, ondansetron could enhance its serotonergic effect. And as I mentioned when talking about the serotonin syndrome, any serotonergic agents, ondansetron may enhance their serotonergic effect, making us concerned of the serotonin syndrome. Patient education will include side effects of the drugs as well as handouts. I really like to give handouts, although everything's supposed to be electronic now, especially with our elderly population that aren't super technical or high tech, knowing how to use their phones or their computers well. A lot of times a paper handout works better, just to make sure that they have not only that they're hearing me and teaching back to me, but that they have handout to read or to refer to if needed. Also, don't take any medications, including OTC medication, vitamins, and supplement without checking with the provider first. And I would say, just since we are worried with ondansetron about serotonin syndrome, I want them to go to the ER if they're unable to contact the provider, if there's any mental change, rigor, tremor, or seizure activity. Also, since we're worried about that QTC prolongation, if they have any palpitations or abnormal heart rhythm, fainting, they would need to present to the ER, or any dizziness. I would say take medication as prescribed for highly emetogenic chemotherapies. Multi-drug regimen may be required. A lot of times the patients will be like, why do I need to take all these if they're all for nausea? We're trying to hit different receptors in that chemoreceptor trigger zone. Store in a safe place away from children, since liver injury can occur if taken too much, or that QTC prolongation or that serotonin syndrome. We want to make sure that the kids are not having access to this. If nausea is not controlled, they need to let us know so that we can add more antiemetics or change the antiemetic needs. According to Lynn's Pharmacotherapeutics for Advanced Practice providers, it states for highly emetogenic chemotherapy consists of aprepitant, dexamethasone, and a serotonin antagonist. In practice, I do see multi-drug regimens, including dexamethasone, used for pre-chemotherapy, as we saw in our patient. And depending on the drug and treatment plan, I do see it used subsequent days. They'll take dexamethasone on days 2, 3 of chemotherapy, or after receiving their chemotherapy. So we give it pre-chemotherapy on day 1, and then day 2 and 3 they'll take oral doses. For our melphalan patient, I do not see us giving a lot of dexamethasone unless we're unable to control it with the other drugs. A lot of times we use Emen, the fosaprepitant, ondansetron, and then we will then use I'm used to saying compazine, but I'll say its generic name, prochlorperazine, in alteration with the ondansetron, so they can take the prochlorperazine every 6 hours and then the ondansetron every 8 hours, so they'll have something to take in between. We want to be able to have alternate therapies to use, and a lot of times for our stem cell patients, we have Ativan available at bedtime. Another education point is that we'll monitor for bowel changes, as ondansetron can cause constipation, and consider those needs, but currently our patient's having diarrhea. So we just want to monitor that change. Adjuvant or alternative therapies, as I mentioned in the last slide, a lot of times for chemotherapies, depending on their emetogenicity, we will use multi-drug regimens. So other drugs that can be added include glucocorticoid, like dexamethasone, which we did see that was given prior to the melphalan. We have not yet given it after melphalan. Benzodiazepine, Ativan, we did give that prior to the melphalan, and she does have it available for her to take at bedtime or every 6 hours as needed for nausea. A dopamine antagonist like prochlorperazine, we have that available. She could take that every 6 hours, and that she will alternate with her ondansetron. I never recommend that they take the two together because I want them to always have something to take if needed a second time. Scopolamine patch, if these other forms don't work, we do sometimes add a scopolamine patch behind the ear just to help dry them up, and hopefully that helps with the nausea. We can also do antipsychotic, such as olanzapine is used off-label for chemo-induced nausea and vomiting, such as Zyprexa. I see that given a lot in our outpatient oncology center. If these other forms don't work, so if they had dexamethasone, if they've had Ativan, if they've had prochlorperazine, if they've had ondansetron and none of that's working, I will see the doctor start to prescribe Zyprexa, usually just a one-time dose at night to help them get through the night, or sleepiness, to help them sleep and kind of suppress the nausea for a little bit. We also have therapies that don't include medications, ginger root. So some patients will use ginger. They'll suck on ginger heart candies, or they will like the ginger root to try to suppress the nausea. Ice chips we do recommend to help with nausea as well. There's aromatherapy, lavender, peppermint we use. My old place of work had something called Quiz Ease, and you just like spun it, and it would open it up just a little bit to release the smell, like the peppermint and lavender, to get those olfactory senses and hopefully help with the nausea. Also a decrease in stimuli. We decrease the lights, decrease the TV, the noise around, and then meditation. In summary, we're partners with the patient, so we want to work with the patient to complete a thorough assessment of her nausea. Is it impeding nutritional intake? Does anything improve it? Does anything trigger it? We want to work with her to come up with an effective treatment plan, as this will help the patient feel they're a participant in their care and help with adherence to plan. As I mentioned previously, that a lot of times it takes multiple drugs, so explaining to them, and that's part of our education as well, like explaining to them like, hey, this Zofran doesn't work for me. Okay, we're going to add something to it. Why add something to it instead of just getting rid of it? Well, the synergistic effect of adding all the medications together, the amend plus the ondansetron plus the fluorocorticoid plus Ativan, like they all have a synergistic effect where they're going to help each other work better, versus like if we take one away. Educate on medications and side effects, precautions, and when and where to seek further care. Like I said, with ondansetron, we're worried about that serotonin syndrome. If we do start to add things like Zyprexa or things like that, we want to make sure that they know that they need to seek care if they start to have these side effects. As I mentioned multiple times now, for CINV, usually a 2 to 3 drug regimen plan is necessary. Sometimes, like I said, even more drugs. I just had a patient 2 days ago. She was on Zofran, dexamethasone, compazine, and Zyprexa. So she was already up to 4 drugs. And then we want to follow up on the effectiveness of the medication. So, okay, we're going to start with Emend or fosaprepitant, ondansetron, and fluorocortisone. Okay, these are not working. What else can we add? Do we need to add a scopolamine patch? Do we need to add the Ativan? Do we need to add something else? Do we need to add dexamethasone? Our book did say dexamethasone, so fosaprepitant, a serotonin antagonist like ondansetron, and dexamethasone. But as I mentioned in my place of work, I don't see dexamethasone being the third drug quite yet. Yes, as pre-medication, but not quite as post-medication, depending on the chemotherapy. And in melphalan, we have not used it post yet unless we can't control the nausea with all the other stuff. And sometimes patients don't want to take dexamethasone because they don't like the side effects of the steroid. In fact, I had a patient yesterday, nausea, can't keep anything down, vomiting, and she still refused to take the dexamethasone because she didn't want to deal with the side effects. So just to, make sure that we're listening to the patient and providing them with alternatives, even though maybe it's not what we're used to doing or what the most standard is. They're very active participants in their care. And here are my references. Thank you very much.